Okay, good afternoon. Not sure that this is the easiest time of the day to be speaking to people. We're hitting mid-afternoon when everybody's energy is kind of flagging. So make sure your camera's turned off, which most of you are. Stretch, move around a little bit if you haven't already, as we go on with this next topic. Why are we talking about the topic of managing hospitalizations and emergency room visits today anyway? To understand why we're doing that, I'd like to talk to you and give you some statistics. You'll find as I go through this presentation that I kind of like statistics. I think they help convey to us in a very concrete way in many instances the importance of some points or some issues. The person who has dementia in general is twice as likely to seek emergency care and to be admitted to the hospital when compared to an older adult without dementia. In one survey of caregivers of individuals who had LBD, 64% of those caregivers reported a crisis during the previous year. And of those who had a crisis, 73% went to the emergency room for help. At least 85% of people with dementia have one or more other chronic conditions that can get out of control or cause their own set of problems. And many of the people with dementia have as many as 5 or 6 other conditions that are not related to the dementia itself. In general, about 75% of individuals with dementia who are 75 years or older and functionally independent at admission to a hospital are not functionally independent at discharge. Let me say that another way. 1 in 4 people living with dementia who are hospitalized, or about 25%, are discharged at the same functional level at which they were admitted. About 2 in 4, or 50%, have a functional decline in the hospital that persists of at least one level of care and require additional support services when they return home. And another 1 in 4, or about 25%, have significant functional declines from a hospitalization and will die within the next 3 to 6 months. These percentages are based on general dementia diagnoses, and they may be a little different for admissions for persons with Lewy body dementia alone. But the fact remains that we are talking about this topic today because emergency room and hospital visits can cause significant problems for people living with dementia. Let's look at another piece of information. In the United States, it's estimated that somewhere between 20 and 40% of all hospitalizations are preventable. And in stressful situations, caregivers are typically the ones who decide when a person needs to go to the emergency room as opposed to being managed in a different way. So why do we have hospital visits anyway? Some of these reasons are related to pre-existing conditions that I referenced earlier that may be exacerbated by the dementia, and some are related to the symptoms of the dementia itself. Falls and fainting. Falls seem inevitable as dementia progresses and are probably even more prevalent in LBD because of the Parkinson-like symptoms and the autonomic dysfunction. Approximately 1/3 of patients with LBD have repeated falls and fainting. Remember that many dementias, as Dr. Bazzoki pointed out, are mixed. So these symptoms may occur even if LBD is not a part of the formal diagnosis for your loved one. Heart disease. This includes heart failure, heart attack, coronary artery disease, or what's been called in the past narrowing or hardening of the arteries, and heart arrhythmias. Any of these may result in decreased blood flow to the brain, further compromising the brain that's already challenged by dementia. Heart disease is still the leading cause of death for individuals over 65 years of age. GI disease or dysfunction. One of the most frequent problems seen in individuals with dementia is constipation. Age-related structural changes in the large intestine, lack of exercise, not drinking enough fluids, all are common occurrences in an individual with dementia and can result in even more problems with constipation. Medications such as diuretics or iron supplements and medical conditions such as diabetes might also contribute to constipation. Constipation is uncomfortable, we know that, but for a person with dementia who cannot often express what's bothering them, or at least not explicitly enough that we can understand all of the pieces of it, you may get reduced appetite, urinary retention, more confusion, and ultimately fecal impaction, which is the inability to pass stool and has to be dealt with by a medical provider. COVID or pneumonia. COVID is now the third leading cause of death in older adults. Research has shown that the person living with dementia is twice as likely to get COVID compared to a person without dementia. And that's even when you adjust for age, sex, whether the person lives at home or in a facility, and similar pre-existing conditions. Pneumonia is one of the most common causes of death in older adults with dementia. In general, people with chronic diseases like diabetes, heart disease, and COPD or lung diseases, all of which are prevalent in the older population, have an increased risk of pneumonia. Inactivity, pooling of secretions with difficulty swallowing, and aspiration or swallowing liquids or foods that go into the lungs instead of into the stomach, are common as dementia progresses. Several studies have reported that people with dementia tend to die more often from pneumonia, maybe with an increase of as much as twice the rate of individuals who do not have dementia. Urinary tract infections, weakening of the bladder and the pelvic floor muscles, which occur with age, and enlarged prostate, which is common in many males, may make it difficult to empty the bladder completely, or may cause incontinence. Incontinence itself, especially in females, is a risk factor for urinary tract infections, as is being overweight, having nerve damage from diabetes, and taking certain medication. UTIs are another thing that can cause pain that may not be recognized by the person living with dementia, and incontinence, and can cause behavioral changes. Caregiver depression and exhaustion. The results of one study that I read pointed out that caregiver depression and exhaustion was frequently a reason for visits to the hospital or the emergency room. And it's easy to understand why that might be the case. When you get too tired to deal with a problem, you're going to look for an answer. And for many of us, going to that place or those places for medical care is the answer we think of in a circumstance where we're very tired and we're very pushed to do something right now. Neuropsychiatric or behavior problems. In one study, neuropsychiatric symptoms accounted for 40% of all hospital admissions for individuals with dementia. Visual hallucinations, behavioral and mood symptoms such as depression, apathy, anxiety, agitation, delusions, or paranoia are all features of Lewy body dementia. These symptoms are estimated to occur in about 90% of persons with LBD at some point in their disease process. And they are the main determinants of whether extra care is added to help at home or the person with LBD is moved to a facility to live. I want to take a minute, and talk about delirium. Dr. Bazzochi talked about this a little bit. I want to say just a little bit more about it. Delirium is a state of acute confusion that develops over a short period of time, typically hours or days. A person with delirium may hallucinate and or become paranoid, and they may have increased activity, decreased activity, or alternate between the two. Delirium is frequently mistaken for a sudden worsening of dementia, and it can be caused by a combination of infection, stress, and pain. It may be reversible if identified early. And it's critical to identify it early and treat the underlying condition as quickly as possible, because delirium is associated with poor outcomes, including death. Roughly half of the patients who develop delirium die within 6 months. Delirium may also hasten cognitive decline. One study found that the rate of cognitive deterioration for up to 5 years after hospitalization in someone who had delirium was roughly twice that of the person with dementia who did not have delirium. The longer delirium lasts, the poorer the outcome. Delirium is more common in LBD than it is in some other dementias. Fluctuations in cognitive function, which have been mentioned several times already, occur in about 58% of those with LBD at the time of presentation to a hospital, and in about 75% of individuals with LBD at some point in time in the course of the dementia. Expected fluctuations in LBD make it particularly difficult to distinguish between LBD itself and the delirium. When delirium is diagnosed, one of the first things that happens in terms of treatment in a hospital situation is that a person is given Haldol. As many of you probably know, using this medication in a person with Lewy body dementia is an absolute no-no, because many individuals with LBD have a severe sensitivity reaction to Haldol that can cause complications up to and including death. This is true of some of the other typical antipsychotic medications that are used. So, what kinds of things cause the problems that occur during hospital visits? Imagine for a minute being upset or in pain, lying on a stretcher, perhaps strapped down because you're agitated, with strange people talking to you, but you can't understand what they're trying to say. Someone's wrapping something around your arm and squeezing it as they try to take your blood pressure, and someone else is sticking an IV in, and all of this is occurring when you're in a strange place. Add to that lots of light and loud noise, and you can understand easily why agitation is a very significant concern in people who go to the emergency room are admitted to the hospital, regardless of the initial presenting symptom they had. In order to treat these symptoms of agitation, many times new medications, as I've said, are added. More than 50% of people with dementia are prescribed new medications when they visit a hospital. And antipsychotics are administered during 40% of hospitalizations. Because the goal with hospital care or emergency room care is to rapidly as possible deal with an issue, several medications may be started at one time. There's no start low and go slow, which Pat's already pointed out is a very important thing to remember. And medications that are added too quickly with too many at a time at too high a dose may do nothing but increase the agitation that a person is having, creating a vicious cycle. Unfortunately, also, as Pat has talked about, many staff are still unfamiliar with dementia in general and with LBD in particular. Hospitals are built on routine and adherence to procedures. They focus, especially in the emergency room, on the presenting problem, and there are frequently not enough staff to provide the individualized level of care that would be desirable for any patient. So you're in the hospital or the emergency room for one purpose, but there are all kinds of new problems that can arise during a hospital visit. Delirium may be caused by the problem that caused the emergency room or hospital visit to start with, or may be the result of that hospital visit. Remember that I said that stress and infection contribute to the development of delirium. Falls and fall-related injuries. A person who goes to the hospital is likely to be weak from whatever problem caused the need to go to the hospital to start with, plus the effect of the dementia. They're often confused and unfamiliar with the bed and with the room. They're not likely to remember how to use a call bell. They're more likely to use a walker or some kind of other aid for ambulation. And in general, the fall risk in an elderly person with dementia who has an abnormal gait and any balance problems is 3 times greater than for an elderly person with dementia who has a normal gait. People who go to the emergency room or the hospital are more likely to have urinary incontinence and vision problems. So they're in a hurry to get to the bathroom if they have to go. And they can't see well where they're going in a room with which they're unfamiliar. All of these are perfect setup for falls and fall-related injuries. Staying in bed longer or being moved from bed to bed, as one might be when they go from the emergency room to X-ray or for some other kind of procedure, makes it more likely that one will have skin tears or skin breakdown and increases the risk for infection, further immobility because of those skin issues, and pain. Untreated pain is a problem in hospitals, and we don't expect that to be the case. A study done in 2000 and reported in the Journal of the American Medical Association looked at the general approach to pain control in hospitals, using specifically the number of procedures patients had and the pain relief if they were admitted for a hip fracture. Those with dementia had the same number of procedures done, but received 1/4 the pain medication of those without dementia and 3 times the antipsychotics. Again, Haldol was the #1 antipsychotic used in the study. The combination of the antipsychotics and the pain can cause decrease in blood pressure, cardiac arrhythmias, blurred vision, urinary retention, and more difficulty walking. Then the functional decline and the increased risk of death that are associated with visits to the hospital, we've already talked some about. So, what's a caregiver to do? First of all, take care of yourself. Again, Pat's already talked about this a little bit. As a caregiver and the primary person making the decision about whether to go to an emergency room to seek treatment, you have to have the capacity to think through the possible options for care and to make clear decisions. Remember that as a caregiver, you are now the most important person in this individual's life. The question of how to be a good caregiver has many answers, but taking care of oneself is always one of them. Taking care of yourself doesn't have to mean going away for days at a time for a respite, although that's an excellent idea if you can make that happen. It's more likely to mean taking an hour here and there for a walk outside, listening to music, reading, getting a massage, or any activity that you find personally relaxing and refreshing. Recruit and educate team members to help with information gathering and decisions. Again, Pat's already talked about a team in caring for a person with Lewy body dementia. Remember that dementia caregiving is a team sport. Have at least one member of your team that you can depend on who understands your priorities and who can help you think through decisions. I'm going to give you a personal example of why this is important. My husband, Roy, ultimately died of an acute heart attack. When I was with him, he was in assisted living at the time, and I was with him when he started having symptoms. What I had in my head was, we are not going to the hospital. That had been a commitment that I'd made a long time before. We're not going to the hospital. We're not going to the hospital. But it was clear that he was having major problems with pain control that couldn't adequately be addressed in assisted living. Fortunately, our younger daughter was available and came to the assisted living facility and very clearly said to me, "Mom, the priority now is to make Dad comfortable. And if we can only do that by going to the hospital, that's what we need to do." And she was exactly right. Decide what's important and what's most important in terms of quality of life and the length of life at this point in the dementia process as you're making a decision. As early as possible after the diagnosis of dementia, you need to think about some of the possible future scenarios and how you would respond to them. For example, people almost always at some point ask questions about CPR. CPR success rates are only about 15% for healthy individuals, and they're almost 0% for those who are older, more frail, or those who have dementia. Even if a person survives CPR, they may do so with broken bones and with permanent brain damage in addition to the dementia that was already there. Is that really the way you want to go with your loved one, or your loved one would want to have happen to them? What's important, though, may change multiple times as the dementia progresses. So you have to continually re-ask yourself, what is it that I want for this person, or that I think this person would want for himself at this point in time? What makes sense versus what is possible? Know this yourself and convey it to family, other caregivers, those people on your team, and to staff at facilities. such as the hospital and the emergency room. That can be done any number of ways. One way that it can be done is using a MOST form, M-O-S-T, which is medical orders for scope of treatment, or a POLST form, P-O-L-S-T, which is portable medical orders. The POLST form was the primary form that was originally developed. The MOST form is North Carolina's adaptation of that form. This form addresses such things as the use of antibiotics, IV fluid, CPR, aggressive treatment in intensive care. Make sure your support person knows what your thinking is about each of these things also. Discuss what to expect with this kind of dementia, again, at this point in time, with the primary medical provider or with the specialist that's seeing your loved one. Talk with whomever is in charge of providing the dementia care about what to expect as the changes occur with dementia. Talk with other medical providers about comorbid diagnoses and how they might impact the dementia, and with the dementia provider about how those comorbid diagnoses may impact the dementia. Make sure all of your medical providers are aware of your goals for care. Ask questions like, what should I do if he falls? What can I do if I think she has a urinary tract infection? Think about adding palliative care or hospice services to your team. Many of us avoid using those services, thinking that they are services that mean that we're giving up on our loved one and that we've resigned ourselves to the fact that they have only a short period of time to live. Learning to make decisions that are appropriate for the situation that your loved one is in at any particular time is not giving up. It's doing the best you can and honoring that person in whatever way you can with the decisions you make. Palliative care or hospice services puts a medically knowledgeable person on your team who knows you and your loved one and whose primary goal is to be on your side. Understand the pros and cons and alternatives for any recommended treatments. What is it that you hope to accomplish with these treatments? Don't be afraid to ask questions and to ask for clarification of answers. Always ask yourself, what difference will this make for my loved one? And don't be afraid to opt for only comfort care if that seems to be the most appropriate approach at a certain point in time. Be able to describe what the person living with dementia is typically like and what differences you're seeing. This goes back to a lot of what Pat said when she's talking about describing things to a physician. You know that person living with dementia better than anyone. But when you're describing, be as specific as possible about what is happening. Is he sleeping 20 hours a day instead of 9 hours? Has she stopped eating anything and is only drinking 8 ounces of fluid a day? Does he moan and grimace even when just lying in bed? Is she pacing the floor for an hour or more at a time and trying to hit anyone who speaks to her? Your knowledge is particularly important in assisting medical personnel to differentiate between symptoms that may be normal manifestations of LBD and delirium. It's helpful to create and maintain a record of your loved one's changes over time after the diagnosis of LBD. This record should include medications and normal readings of blood pressure and temperature, especially since blood pressure and temperature may be very different from accepted norms, but still be normal for your loved one. For example, a blood pressure of 80/45 may indicate a critical health crisis for someone without LBD, but may be within the typical variation for your loved one. These medical records might also include such things as changes in how the person acts, communicates, eats, moves, or sleeps. One of the references cited at the end of this presentation provides suggestions for what types of information one might record and how to organize that information. One way to begin the process of recording information is to use the LBD Diagnostic Symptoms Checklist from LBDA. You can mark symptoms that are present with the date a symptom started and record subsequent changes on additional copies of the checklist. Make sure that this information is updated regularly and that it's available in hard copy in a notebook that stays with you or in an electronic form, preferably on your phone, so that it's there all the time. There's a maximum that's sometimes used in medicine that says, if you can't measure it, you can't manage it. One article I read suggested that for persons with LBD, this maxim should be changed to say, if you aren't sure what's normal, you can't be sure if this is abnormal. If you think pain is an issue, try Tylenol. It's an appropriate first-line approach for most people for mild, persistent pain. Studies again have shown that 60 to 80% of nursing home patients with dementia regularly experience pain. And 1 in 3 of those residents have moderate to severe pain. Patients with dementia, with more severe dementia, experience more pain than those with less severe dementia. Try physical movement, music, massage, heat, lidocaine patches, and human interactions. And your presence all help to reduce pain in someone. Be proactive if you think problems are developing. Remember that a medical care provider who sees your loved one in the emergency room or after admission is highly unlikely to be the one who knows anything about your loved one. Know how to best contact the regular medical care providers, especially if you need guidance urgently. Can you use the patient portal? Is a phone call preferred? What happens after office hours? Are there extended office hours on any days? Can a telemedicine visit accomplish what we need? Can I bring a urine specimen by the office? What if a home COVID test is positive? Have medical information ready for an emergency. As we've already talked about, this needs to be current medical information that can be part of that, maintaining that health data. Make sure that you have current medications, allergies, current diagnoses, and current providers, preferably with their telephone numbers. Make sure that you have some designation that says do not give these particular medications, especially for people with LBD. Have your insurance information and a photo ID, advance directives, and healthcare power of attorney, and anything else that might help staff better understand your person living with dementia. And don't forget your cell phone and your charger. One way to convey medical information is by, or at least some information, is by using this card that is a medical alert card that was developed by the Lewy Body Dementia Association. The front of the card has just some general information on it that we've already talked about. The back of the card has a little more specific information and talks about treating individuals with LBD who are having psychotic episodes, thinking about whether these are regular fluctuations in LBD or the result of delirium, a warning about the use of antipsychotic medication, steps for providers to take when a psychosis occurs, and information about a reference for physicians that they can use in treating behavioral disturbances in LBD, including the website where it can be found. You may want to print a copy, in fact, of that document for yourself to keep on hand with information you take when you go to the hospital or emergency room. Dr. Bazzoki also told me before this workshop began this afternoon that she has been involved with LBDA in helping to revise this medical alert card and make it perhaps a little simpler and more straightforward for medical providers to use. Hopefully that revised card will be available on the LBD website within the next couple of months. Don't expect staff to have expertise in caring for persons with dementia. Try to make sure that either you or another member of your team stays with the person who has dementia at all times. This will be more calming for him or her and allow you to advocate for what works best. Be prepared to help any ER or hospital staff person to understand dementia in general and the specific needs of your loved one with LBD in particular. What name do they like to be called? What makes her agitated? What behaviors are typical, and so on. Control the environment as much as possible. Know what works best for keeping your loved one calm and ask to use it. Music, massage, turning off alarms on equipment, white noise, turning out lights, or at least decreasing the level of lighting, letting you explain what's going to happen rather than the medical provider explaining that, and perhaps objects from home that are calming to your loved one. Know your rights and hospital resources. I think we've all been given hospital bills of rights, patient bills of rights, so many times that we basically ignore them now, or we don't even ask for them if we have the option. However, I went back and looked at the patient bill of rights for the UNC hospitals. Here's part of what it says. A patient has the right to be treated in a dignified and respectful manner, free from neglect, exploitation, or abuse, with good quality care using high professional standards provided by competent personnel in a safe environment. You may be the one who has to advocate for that dignified and respectful treatment. Another thing that it says in this Bill of Rights is, except as medically necessary, a patient has a right not to be awakened, to be free from duplicative procedures, and to avoid treatments that could cause discomfort. And a patient has the right to effective communication in understandable terms. Again, these may mean that you have to do more for your loved one with dementia than the medical staff has to do in helping make sure that these rights are respected and that they are implemented. All hospitals now have patient advocates or representatives. These people work with the family to understand concerns and to help resolve issues that arise in the hospital. Hospitals also have ethics committees. These committees don't usually work directly with families, but help make decisions and can facilitate discussion between parties when there is a disagreement about how care should be carried out. They're also charged with making sure each party is hearing what the other party is saying. So a trip to the hospital may be unavoidable, but our role as caregivers is to minimize the negative impact of this trip while advocating strongly for what's best for our loved ones. I hope you've learned some ways to do that during this presentation. There are 2 slides here at the end that provide you with some resources. And again, I noticed one of the things that's been said on the chat is that these slides will be available to you later. The second slide is some of the resources that are currently available through the Lewy Body Dementia Association website. If you've not looked at that website, you may need to, it would be helpful if you would go explore it and look at all those resources and read some of what's available there that might be helpful to have on hand for hospital and emergency room visits. Thank you.